let you. And Professor Friedman, I will let you turn on your microphone.
Thank you.
Okay, let's get started then.
Yeah.
Good evening, good afternoon, or good morning, wherever you are in the world. Welcome to our online conference today, yesterday, or tomorrow, whenever you are. Happy New Year. First of all, this is our first session in this new 2023. Before giving the floor to our dearest guest, I would want to introduce our team. I'll be the moderator of today's conference. My name is Madonna Akhopadze. I'm the last year neurosurgery resident in Georgia, Sakartvelo, and I'm also a PhD student in Tbilisi, capital of Georgia. This online education meetings have started with Professor Hasan Kamil Sucu, who is present here. Thank you, Dr. Hasan. He's the program manager of the neurosurgery department of the İzmir Atatürk Training and Research Hospital in Turkey. And it goes on with the contribution of all the residents and also with the contribution of all the neurosurgeons who have graduated from the same department. And as well, neurosurgeons and neurosurgery residents from nearby countries such as mine, Georgia, Sakartvelo, Bulgaria, Ukraine, Pakistan, Kazakhstan, and many others. A couple of words about the protocol of today's meeting. All the microphones will be turned off during the presentation of the lecture to avoid any noise or voice pollution. You can ask your questions by writing them to the chat section of the Zoom program. And at the end of the presentation, your questions will be asked to the lecturer, and I assure you all of them will be discussed. Mutual discussion is not appropriate for the format of our meeting. And now, I would like to introduce our dearest guest, Professor Dr. Deborah Friedman. She's a neurologist specializing in the headache medicine and neuro-ophthalmology in Dallas, Texas. She was the founding director of the Headache and the Facial Pain Program and the Cerebrospinal Fluid Dynamics Program at the University of the Texas Southwestern Medical Center. She's the board certified in neurology and headache medicine and is a fellow of American Academy of Neurology, as well as American Headache Society, American Neurological Association, and the North American Neuro-Ophthalmology Society. She served on the board of directors of American Headache Society and the Southern Headache Society. As a past president of the North American Neuro-Ophthalmology Society and on the steering committee for the Idiopathic Intracranial Hypertension treatment trial. She has published over 130 articles in peer-reviewed journals and over 27 book chapters. Her key interests are intracranial pressure disorders, cluster headache, and a migraine. And now it's my distinct honor to present Dr. Deborah Friedman. The virtual stage is yours. You can start your screen sharing. Thank you.
Well, thank you. Thank you, Madonna, for that really kind introduction. It is an honor to be here. Happy New Year, everybody. And let's get started, I guess. Hello. There we go. All right. I really don't have any relevant disclosures. What we're going to talk about today are, first of all, how to make the diagnosis, both if the patient has papilledema and if they don't.
Excuse me,
talk about the medical and the surgical management. And everything that we use to treat this condition is considered off-label. So, you know, it sounds kind of basic that you want to make the correct diagnosis, but we'll talk about at least what we're seeing over here in the US as far as misdiagnosis in a second. But the diagnostic criteria require that to make a definite diagnosis, the patient needs to have papilledema. They should have a normal neurologic exam, except perhaps a sixth nerve palsy or a bilateral sixth nerve palsy. Their brain imaging should only show signs of pseudotumor, so you've ruled out a real tumor or another process. And their
sorry to interrupt you.
puncture. You okay?
You're not sharing the screen. Sorry to interrupt.
Oh, I'm sorry.
Mm-hmm.
You didn't miss anything, but let me go get it. Share screen. Where are you? Share. How's that? Share? No, that's not sharing the screen. Okay, I am finding like nothing here. Hang on. Video, share the
You
screen.
should go
Okay,
back to
I
the
got it.
Zoom
I got it.
meeting. Yeah,
Sharing?
that's great.
Okay, I'm sorry.
Perfect.
Okay.
Sorry, can you make it? Okay,
That okay?
it's full screen now. Okay, yes.
Not known for my technical skills. All right, the lumbar puncture should show an elevated opening pressure. So in adults, currently that's defined as 250. That may be a little artificially low. It's based on old data. In children, it's 280 millimeters of spinal fluid. And if the child is not sedated for the tap or not overweight, then it's more than 250. The CSF content should be lower. So if the spinal tap is done, but the opening pressure is not quite there and the patient has true papilledema, you can make a possible diagnosis, and we recommend that you probably repeat the spinal tap. Now, what if the patient doesn't have papilledema? That's when things start to get tricky. If they have all of the other criteria and they have either a unilateral or a bilateral 6 nerve palsy, then you can make a definite diagnosis. Unfortunately, in real life, this doesn't happen very often because most times people get the papilledema first and then they get the 6 nerve palsy. The other way to make a suggested diagnosis if they meet imaging criteria and all of the other criteria except for papilledema. So if they have 3 out of 4 empty sella, flattening of the back of the globe, distension of the perioptic subarachnoid space with or without a tortuous optic nerve, or transverse venous sinus stenosis, which is usually bilateral but not always, then you can make a suggested diagnosis. And we actually went through and did a study after we wrote the criteria and found out that the imaging criteria had a sensitivity of about 60% and a specificity of over 95% in both adults and in children. So when you're seeing the patient and you're taking the history, there's some things that we should ask about. The most common symptom is headache. It's present in almost everybody at diagnosis. And when we did the idiopathic intracranial hypertension treatment trial, we actually asked about various aspects of the headache and then tried to look at the phenotype to see if it was similar to any of the primary headache disorders. And it turns out that by far and away, the most common description of the headache is it sounds like migraine or it sounds like tension type headache. Sometimes it's a new daily persistent headache. Patient never had a headache. They got a headache. It never went away, but it doesn't usually come on as a thunderclap headache. You know, all of a sudden, bam, it hit me. The location can be almost anywhere. The severity is also quite variable. Not everybody has constant headaches. Sometimes they're intermittent. But in people who have a history of migraine or another primary headache disorder, they can typically differentiate this as being different. There's usually no positional component. So we like to think about high intracranial pressure causing headaches that are first thing in the morning and they're worse when you lie down, but that's not what people typically report. And even after people have successful treatment and their intracranial pressure comes back down to normal and their papilledema goes away, about 2/3 of people continue to have headaches. So they become headache patients. And that's one of the reasons that I became interested in headache and became a headache doctor. So we're also going to ask about transient obscurations of vision. That's temporary loss of vision. It usually lasts seconds, maybe a minute. Typical story is the patient bends down, they stand up, and all of a sudden their vision goes out. People can have back pain or neck pain. Pulsatile tinnitus is common. Some people have non-pulsatile tinnitus. And then there's everything okay?
Yeah.
Yes.
Everything on the left side were things that came up in the idiopathic intracranial hypertension treatment trial. So other symptoms that are not infrequent include dizziness, subjective visual loss, nocturia, brain fog, as we call it over here, radicular pain and double vision. I did a study very early in my career with a colleague, David Streeton, who's an endocrinologist, and we found that women with IIH tended to retain fluid systemically, and it was orthostatic fluid retention. Photophobia can occur, and often we'll get a history of recent weight gain. So these are the common MR findings. They're not really specific for IIH, but these are the things we look for. Can you guys see my cursor?
Yeah.
Okay, so sagittal view of the orbits, we're looking for the tortuosity of the optic nerve. For the med students, the optic nerve is the kind of light gray, and then the perioptic subarachnoid space is the dark because it's T1 weighted image and the fluid is dark. So you can see this thing over here, it's sticking into the vitreous cavity. That's actually the papilledema. And if you look really closely, I think you can make out that the back of the optic, back of the eyeball is flattened because of the pressure coming from further back. I like to look at the T2 weighted images where the fluid is bright. It makes it much easier to see the flattening of the posterior sclera. You can more easily appreciate the high signal of the perioptic subarachnoid space. And it's a little generous up here, more close to the globe. And in these images, the optic nerve head actually looks dark, and you can still see the optic nerve head protruding into the vitreous cavity. The most common sign is an empty cella. And this is like the mother of all cellas that actually is from a man who was suspected to have IIH. And I followed him many years later. But you can see that not only is the cella quote unquote empty, but it's also expanded. Okay, so that's what we're looking for. And then one of the other signs that we look for is a prominent Meckel's cave. So Meckel's cave down here at the base of the brain, and with the high signal over here, because of the fluid, you can see that there is a enlargement of Meckel's cave. But basically, IIH, if it's present long enough, that it can thin any part of the bone in the skull. So there's also reports of just generalized skull thickening. You can get meningoceles from IIH. You can get thinning of the bones that are in the ear canal, in the inner ear. So, you know, almost anything can happen that's related to thinning of bone. So what about misdiagnosis? There was a study that was done at Emory University, Atlanta, and they did a retrospective review of hundreds of patients they had seen that were referred in to either rule in or rule out IIH, the idiopathic form. And they found that the most common reason to miss the diagnosis was the failure to perform a proper fundus exam, which kind of makes sense. And then there were a lot of people that got overdiagnosed. So people that had pseudopapilledema, which can be really hard to discern from true papilledema without using the ophthalmology tools, but misinterpreting the optic disappearance, improperly performed lumbar puncture. So the patient was sitting up, for example, the patient was on their stomach, and the correction wasn't made for the change in the position. And so the pressure reading was erroneously high. Patient was actually treated before the lumbar puncture. We see this a lot. Patients get put on acetazolamide, then they get sent for their LP, and nobody stopped the acetazolamide beforehand to find out what the pressure really is, so it looks normal. Or an inappropriate diagnosis based on incidental findings, which I'll talk about next. And so I think it's important to keep in mind that this is a package deal of symptoms and signs. You don't make the diagnosis based on an elevated pressure alone or MRI findings alone. You want to have a good story and supporting evidence. So this is another study done by the same group. They had a aspiring neuro-ophthalmologist who was a medical student at the time. And he was sent down to the MR suite with a fundus camera and a bunch of consent forms. And what he did was he took fundus photos of 296 patients who were having an MRI for basically any reason, an MRI of their brain. The population was not really representative of IIH. They were older, 63% female. We know that IIH is probably 90% females. But the reason that they were undergoing imaging was that either they were having surveillance for a brain tumor or a previous brain tumor. Only about 8%, I think it's supposed to be 8.8, actually had headache as the reason for their imaging, and a very small percentage had a history of intracranial pressure disorder. they found that half of the patients in the scanner had at least one radiographic sign of IIH. 5 of them out of all of those 296, when they looked at the photos, the fundus photos, turned out to have papilledema. So you can see the percentage of the abnormalities that they saw. A third had an empty cella. About half that number had an enlarged Meckel's cave. Even perioptic fluid was present in almost 11% of people. So they did not look, most of those patients did not have an MR venogram. So we don't really know how many had transverse sinus stenosis. Only about maybe half of them had an MRV and 3% had transverse sinus stenosis. And we know that that's not specific to IIH either. So of the fundus photos, again, 5 patients had papilledema. 2 of them had a history of IIH with worsening headaches. 2 had a glioblastoma, and 1 was being scanned because they had temporal lobe seizures with a meningoencephalocele. As the number of the MR signs increased, the prevalence of papilledema increased. So those who had all 4 signs or maybe more, 40% of them had papilledema. So they concluded that MR signs were common, but rarely associated with papilledema. And when patients go into the scanner and these findings show up incidentally, and their history and their exam does not support a diagnosis of IIH, then there's no need to pursue that diagnosis. So why might people not have papilledema? Well, maybe they had it before and it went away before you saw them. Maybe they have previous optic atrophy. Maybe they were examined very early in the course of the disease before they got the papilledema, or maybe they have a concurrent CSF leak. So both skull-based leaks as well as spinal CSF leaks can occur as a consequence of high pressure. We want to make sure that the patient doesn't have a secondary cause. And there are a lot of things that have been reported as being associated with pseudotumor. But the things that we're really concerned about are, first of all, anything that obstructs venous drainage from the brain, such as a venous sinus thrombosis. There are medications, many, that have been associated with it. The most common are either the tetracyclines, any of the retinoids or the vitamin A derivatives, such as all-trans retinoic acid that's used to treat childhood leukemia. And the ones that are listed are really the most common. And then there's some medical disorders that are associated with it. Not clear whether that's the cause or not the cause, but the things that we frequently see include sleep apnea, polycystic ovarian syndrome, and then others, as you can see. So what about sleep apnea? I used to only screen men for sleep apnea when they had IIH. Now I screen everybody. But when people have sleep apnea and they go into a period of apnea, it causes both hypercapnia and hypoxia. And it also increases the intravascular volume. And it's the change in blood volume that may be the culprit here. So an episode of sleep apnea can actually increase CSF pressure anywhere from 50 to 750 millimeters of spinal fluid during the episode. Now, most of us do things that also cause an increase in our spinal fluid during the day, but that's during sleep. There's never been a study that looked at the effect of treating sleep apnea in patients with pseudotumor, whether it helps or whether it doesn't. There was a nice study recently that came out in the Journal of Neuroophthalmology that looked at sleep apnea in men with pseudotumor and found that body mass index was the strongest predictor of that. But normal weight women, not overweight women, normal weight men with IIH were more likely to have sleep apnea than controls. There was no difference in the hypercapnia in men with IIH versus control. So it doesn't seem like the hypercapnia is the driver of the high pressure, but we recommend that patients get screened for it if they have risk factors. Polycystic ovarian syndrome is double the rate in women with IIH than in the general population. And similar to other things we'll talk about in a second regarding new treatments, it is associated with androgen excess and central adiposity. But as opposed to women who don't have pseudotumor, but have polycystic ovary syndrome, IIH patients have a distinct pattern of adiposity. And this comes from the group in the UK, in the Birmingham group. They have both increased serum and CSF testosterone, as well as CSF androstenedione. And when they looked at samples of adipose tissue taken from bariatric surgery, it seems like their adipose tissue was kind of primed to make androgens. And there was a study that was done years ago showing that women who had IIH and polycystic ovarian syndrome who were treated with metformin plus diet lost more weight than those treated with diet alone. So let's go into the exam. We're going to assess the vision. That's super important because our treatment is all based on vision. So we want their best corrected visual acuity. The visual acuity is usually affected late in the course of the disease because, like glaucoma, the visual field tends to affect the periphery first. So if you have somebody that has, as presentation, loss of their central vision, that's a bad sign. Looking at their pupils, their motility, the perimetry, which is very important, a dilated fundus examination. And we use OCT, optical coherence tomography. It sometimes is useful if there's a question of subtle disc edema. It's also useful in separating true disc edema from increased intracranial pressure, true papilledema from pseudopapilledema, but it's not really a substitute for an eye exam. And then fundus photos really help us follow the patient. So this is the left eye of a patient with IIH and papilledema, and they have an enlargement of the physiologic blind spot, and they also have a partial superior arcuate field defect, which is one of the more common field defects that we see. We're going to grade their papilledema, and there's a system for doing this. The things that really help you are whether the disc is elevated, whether the optic cup is present or not, whether the patient has what's called a peripapillary halo. So you can see that in stage 1, there's a little bit of a dark ring around the disc. It's kind of subtle. I don't know how well it projects on your monitors, but here in stage 2, you can start to see it better. So around the swollen disc, you can see that the patient is starting to develop this peripapillary halo. And by the time the patient gets to stage 3, the peripapillary halo goes all the way around the nerve. The more severe papilledema, you start to lose the vessels as they cross the margin of the disc. And that happens in stage 3. So there's a nice juicy vein over here. We're going to follow it in, and oops, as it's crossing the disc margin, it gets obscured by the edematous retinal nerve fiber layer. And then as the papilledema gets worse, you can see that more vessels are obscured, and we start to see obscurations of the vessels on the disc itself. So compared to stage 3, where we see all of these vessels coming in stage 4, we're kind of missing some over here. And stage 5, even though this disc does not look so angry because it's a chronic papilledema, all of the vessels crossing the disc, the major vessels, are obscured, and all of the major vessels on the disc are obscured. So some of the things that look the most, exciting really don't help us. So exudates, over here, this person has exudates, this protein leakage, that doesn't really help us grade the papilledema. Hemorrhages, if you look up here on the right, this person also has a bunch of peripapillary kind of flame or nerve fiber layer hemorrhages. That doesn't really help us. But keep in mind that once the patient develops optic atrophy, like this person down here who had pseudotumor, and it wasn't treated early enough and she developed optic atrophy, the disc is going to become pale. The nerve fibers die. And so that nerve is probably never going to swell again. So you can't use it as a barometer for the intracranial pressure. Just be aware that there's some things that can cause pseudopapilledema. The most common is probably optic disc drusen, which are little calcifications that are kind of buried underneath the nerve. And a tilted optic disc, it's hard to appreciate in 2 dimensions, but this part of the disc over here is actually sticking out when you look in 3 dimensions. And the disc is kind of at a funny angle. It's not elevated. It's not elongated vertically. And so, that can be challenging, especially with a direct ophthalmoscope, to tell the difference. So the treatment really requires a team approach, which is where you guys sometimes will help us out. And usually either a neuro-ophthalmologist or the neurologist is the sort of captain of the team. And you need somebody who's going to sort of work with everybody and make sure the patient gets good care. And so there are a lot of things that sort of go into this equation, including dietary management and weight loss for those who are overweight, CSF pressure lowering agents, treating their headaches, looking for sleep apnea, looking for endocrine abnormalities, surgery, other interventional options like stenting or optic nerve sheath fenestration, or shunting, and then ongoing monitoring. So I'm going to show you some data from the IIH treatment trial. This was done a while ago, actually about a decade ago. It's published in 2014. And what we were looking at was the effectiveness of Diamox or acetazolamide versus placebo in the treatment of patients who had very mild visual loss. And everybody also had weight loss management. And our primary outcome was a visual field outcome measure, which is the parametric mean deviation. I'll show you what it is at 6 months. So this is just what our study design was like. We had eligible patients. They had to have a relatively low parametric mean deviation. So a normal parametric mean deviation is -2 or greater, so closer to 0. So relatively mild. They were randomized to acetazolamide or placebo. They also had a weight loss coach. They were put on a weight reduction diet. Primary outcome was the primary mean deviation at, parametric mean deviation at 6 months. We were going to follow them for 5 years, and then it turned out that the government cut our funding. So we didn't get to do that. So what's parametric deviation? It's taken from the visual field machine. So this is a visual field of the right eye. How do you know? Because the blind spot's on the right. These are all the different points. They're 6 degrees apart that the field machine tests. So the patient views with the one with the right eye only. The machine will flash points of light at all of those different places. They vary in intensity, but they're all the same size. So the brightness differs. And the patient just looks straight ahead at a fixation point. And whenever they see this thing flashing out in their peripheral vision, they press a button. So these are actually the data measured in decibels. The software in the perimeter takes those data, compares them to age-matched controls who have normal vision, and calculates the difference between their response in decibels and the normal people's response in decibels. And those are the data over here. And, you know, if it was a normal person, they would all be zeros. And then they average all those numbers. They take the mean, okay? And so the mean is the mean deviation, which is printed out over here. And normal should be less than -2 decibels or greater. So this person is -4.4. And that's what our primary outcome was. You don't have to look at the diagram. We randomized 165 people, pretty much equally to acetazolamide or placebo. And just to note that of the acetazolamide people, only one had to be taken out of the trial and treated in a different way because they continued to lose vision. And those who received placebo, they had 6 treatment failures. So here's what we found. Our primary outcome barely met statistical significance. Truth be told, I would have put money on the trial was going to be negative, but, you know, we made it. So acetazolamide was, why are you hearing this? Sorry, I don't know what's going on. So the parametric mean deviation was better. The improvement was better in the acetazolamide group. They had greater improvement in their papilledema grade, highly statistically significant. Their visual quality of life, the neuro-ophthalmic quality of life supplement, they lost more weight than the placebo group. But the only thing that wasn't statistically significant was the improvement in their headache disability. And yes, their headache disability got better during the trial in both groups, but acetazolamide performed no better in that regard than placebo. So what do we have for medical treatment? We usually start with a carbonic anhydrase inhibitor because it decreased the secretion of spinal fluid from the choroid plexus. The most common one that we use is acetazolamide. It's the only one with level A evidence for IIH because of our treatment trial. And at least for mild vision loss, that is the one that's preferred. We actually went up to 4 grams a day of acetazolamide. I have no idea how people managed to tolerate that, but they did. And it's not a fun drug to take. There are a lot of side effects that are associated with it. For people that don't tolerate acetazolamide, methazolamide is often much better tolerated. It tends to have a little less metabolic acidosis associated with it. If that doesn't work or the patient doesn't tolerate it, we can try furosemide, which also works at the choroid plexus to inhibit CSF secretion, but there's no literature supporting its use as monotherapy. Problem is, if it's combined with other diuretics, they're at high patients at risk for hypokalemia, so you have to really monitor for that. Bumetanide, which is kind of a cousin of furosemide, could be tried. It's never been studied. There are no publications. But acetazolamide, furosemide, bumetanide can be used IV. So if you have a patient in the hospital, that's a good option. Other diuretics, we try them. We don't know if they really work. Hydrochlorothiazide, chlorthalidone. And then for patients who are sulfa allergic, and I think I have a slide about this, who are truly allergic to acetazolamide, the ones that don't have sulfa include spironolactone, which we also use for polycystic ovary syndrome, so it might be a good choice for them too. Triamterene, eplerenone, and then ethacrynic acid. Other options, topiramate, which also has that carbonic anhydrase activity as part of its mechanism of action. There was one study that was done in Turkey, actually, that looked at acetazolamide versus topiramate in patients with mildly affected vision and mild papilledema, and found that basically they did the same, they did well, but the topiramate group managed to lose more weight than the acetazolamide. Somatostatin analog octreotide has been studied in a couple of case series. It has to be given subcutaneously every day for 6 months or more. And they showed improvement in headache, papilledema, and CSF pressure in 27 patients. I will say that my experience with octreotide is very small, but it wasn't that good. Please try to stay away from corticosteroids. Yes, they lower CSF pressure, but we really reserve them for patients who are kind of going blind in front of our eyes, and we need to do something right away to bring their pressure down. But long-term use of steroids is associated with a lot of things that we don't want for pseudotumor, such as weight gain and peripheral edema and hyperglycemia. And keep in mind that corticosteroids being used for any reason can precipitate the pseudotumor syndrome when they are withdrawn. The emerging treatments, this is from, again, the group in Birmingham that are really trying hard to figure out this disease and solve the problem. They first looked at a glucagon-like peptide, which they're on the market. They're used for weight reduction in patients with or without type 2 diabetes, and they improve glycemic control without causing hypoglycemia. It turns out that the choroid plexus also contains these GLP-1 receptors, and studies in animals show that CSF production decreases when they are treated. This is a rat study, I think, treated with receptor agonists. So there's actually a phase 3 randomized trial that just got started. It's based out of Birmingham in the UK, of exenatide, which was reformulated to give once a week in patients with IIH. So we'll see what happens with that. You have to watch out with carbonic anhydrase inhibitors and kidney stones, but actually there are studies that have done that the incidence of kidney stones are no greater in these patients than in the general population. So let's move on to headache management. Not much to say other than please don't operate on them. I know I'm talking to neurosurgeons, don't kill me, but we know that shunts don't work well for headache long-term, and we prefer to manage these patients medically, not surgically, if it's just a headache issue. So the headaches don't really correlate all that well with opening pressure. They don't correlate well with the degree of papilledema or visual field loss. This is based on IIH treatment trial data. We know that medication overuse is common in these patients. So acute medications for pain We saw it in our trial when they did the trial in the UK. They did a weight loss trial. They found the same thing. They also found that patients were much more likely to prescribe opioids than the patients we had in our trial. So we want to select the agent for headache based on whatever comorbidities the patient has, what their headache sounds like, and potential side effects, just like we do in headache medicine. So, there are many, many things that we can use. As a preventive, I like to go to topiramate first because it's also a great headache drug, in addition to having carbonic anhydrase activity. But almost anything that you can think of, you can try, except things that will cause weight gain. So valproate, we try to avoid. Steroids, verapamil can cause peripheral edema. Pregabalin is pretty notorious for causing weight gain as well. We don't want to get patients into a medication overuse headache situation. So we try to avoid opioids or butalbital and caffeine-containing medications. And there's a question of whether caffeine actually is doing the reverse, right, and making their pressure high, because that's one of the things we use for patients who have low pressure headaches. Therapeutic lumbar punctures can be done. A lot of patients, they're not signing up for this, but in certain circumstances, they are useful. It doesn't make sense really why they work, unless the reason that they work is that they expand the venous sinuses in the brain, because we know that when you do a spinal tap, that spinal fluid is replaced, within hours of doing the spinal tap. So patients who are having occasional exacerbations, a lot of times we'll use therapeutic spinal taps during pregnancy. If the patient is, rapidly experiencing vision loss, and we're figuring out what surgical or interventional procedure we're going to do, but they need something to get them through, we might do sequential lumbar punctures or put in a lumbar drain. The value of taking off a lot of fluid has never been established, and you can give somebody a low pressure headache that has pseudotumor, which can actually make their symptoms worse. So, I recommend taking off enough spinal fluid to put their ICP down in the normal range. For patients, again, that are sort of rapidly fulminantly declining, lumbar drain, you can take the spinal fluid off faster than it's produced. So it is a good option for fulminant disease and patients with shunt failure that are losing their vision. Dietary management, we know that pseudotumor occurs primarily in patients who are obese and female, and often have a history of a recent weight gain. Studies have shown that patients who are morbidly obese have a higher grade of papilledema in general, which in turn can be associated with a higher risk for vision loss. Older studies showed that a mean loss of about 6% of body weight was associated with resolution of papilledema. And it's, I think, a good initial goal. Most people can handle that. When you tell them we need to get some weight off, 6% is a reasonable thing to try to achieve. And we know that weight loss also improves the effectiveness of diuretics and acetazolamide. And we usually incorporate a low sodium diet because of the studies that we did way back when, showing that peripheral edema. There have been meta-analyses of bariatric surgery in IIH, and also the recently published IIH weight trial that came out of the Birmingham group that support the use of bariatric surgery for IIH patients. They lost weight faster, they lost a lot more weight, and the patients who were assigned to the medical weight loss group, most of them didn't even go to the sessions to do the program. What they found was that it took a 24% weight loss to normalize the ICP. Now, is that really necessary? I don't know, to produce clinical resolution, but that's what they found in their trial. So surgical treatment, we tend to reserve for patients who are losing their vision. And these are people who have marked acuity loss at presentation, marked visual field constriction, retinal or optic disc ischemia, or rapidly declining vision. And the goal is just to reduce the pressure on the optic nerves. So our options are shunting, stenting, and optic nerve sheath fenestration. Keep in mind that none of these has ever been studied in a randomized trial, and I will show you the data from meta-analyses. And considering how often these procedures are done, particularly shunting. We've been doing shunting for decades and decades. There's a surprising lack of robust evidence in the literature. And again, surgery is not highly effective for headache treatment, especially when the patient has had headaches for years. And we know that after 3 years, about half of them, their headaches are right back, and they've probably had a few shunt revisions. So this is from a very nice meta-analysis that was done. And I don't know why you're hearing this in echo, if you're hearing it, because I'm hearing it.
No, we're hearing well without echo. It's
At one
okay, your
point,
voice is
you know
clear.
what? I had recorded this, and I probably didn't get rid of the recording part. So I'll just let my recording talk. All right, let's go back to shunting, and you can listen to me talk about shunting. Or I can get rid of it. So VP shunt, right? LP shunt. Look at how many studies were done, and look how many procedures are reported. I mean, that's not very many, right? Okay, mean duration of follow-up, several years. The numbers look good. Acuity improved, 55%, 67%. But look at how many patients are in the denominator. Only 29 patients with a VP shunt had their acuity improved in the literature, had their acuity measured. Only 26 had visual fields. 68 had improvement of headache. We don't know exactly what they used to determine that. I don't think it was any validated scale, but a small percent worsened. We see that with all the procedures. And the revision rate is not so great. It's a little worse, at least in the meta-analysis, it was worse for LP shunts than for VP shunts. Optic nerve sheath fenestration, well, that's done by, oculoplastic surgeons usually, so we have better data on vision. 525 procedures. Remember that we have 2 eyes, so a lot of people got more than one procedure because they got it on each eye. The acuity improved in 2/3 of patients. This one we have a slightly bigger denominator. 64% had visual field improvement. They didn't care about the headaches. And visual field or visual acuity did worsen in about 16%. How about stenting? So why do we even think about stenting? Just a little bit about the rationale. Probably there may be some of you that are doing stenting as well. So you can start this diagram anywhere you want, really. But let's say we start with, for whatever reason, the spinal fluid pressure is high. The spinal fluid pressure is high, so it causes the veins in the brain to collapse. You get venous sinus stenosis, or maybe it happens the other way. The patient has venous sinus stenosis for some reason, and it causes the pressure to go high, because if the patient has venous sinus stenosis, they're not absorbing spinal fluid like they should. So if you intervene over here and you do a stent, you're going to decrease the stenosis, right? So the venous system is able to absorb the spinal fluid. The spinal fluid pressure is going to go down. If you intervene over here, lumbar puncture, shunting, you're going to decrease the CSF pressure. The venous sinuses will open up, and they will be able to absorb the spinal fluid. And so that's kind of the rationale for why stenting came to be. So this is done usually by a neurointerventionalist. There are some neurosurgeons who do interventional work as well. Patients are screened with retrograde venography and manometry. So their catheter is inserted and it's sent up into the brain, and there's a little manometer on the end of the catheter. And so they measure the venous sinus pressure, both proximal and distal to the stenosis. So we want to make sure the patient has a stenosis before we go doing this. So on MRV or CT venography or catheter venography, we would determine that. So they measure the pressure proximal and distal. The difference is called the gradient. And it turns out that the higher the gradient is, the more likely the success of the procedure. They will deploy the stent, okay? And so you can see here that the venous sinus is opened up and patent, and then do re-imaging and make sure that everything looks good. There was a study that actually came out of UT Southwestern with a very cute name called 50 Shades of Gradient. And they found that patients who had a gradient of at least 21 millimeters of mercury had a better outcome than those that had lesser of a gradient. So these patients have to be on antiplatelet therapy, both prior to the procedure and 6 months after. They can have restenosis adjacent to the stent. You have to have follow-up imaging to make sure that the stent is patent. And I'm going to switch slides because apparently I screwed that up too. This was from a meta-analysis of stenting by the same group that did the other one. 155 patients followed for a couple of years. Most of them had improved acuity. Most of them had improved visual field, papilledema, and headache. They had a 12% complication rate. But keep in mind that there are some serious complications that are reported in the literature, including subarachnoid hemorrhage, subdural hematoma, epidural hematoma, venous sinus thrombosis, herniation, and death. Is it common? No, but it has been reported. So this was a prospective observational study of stenting that was done by a neuro-ophthalmologist, and he required at least an 8 millimeter gradient and at least 6 decibels of parametric mean deviation loss. And again, good results. Headache improved, pulse synchronous tinnitus improved. This is a technique we used for treating pulse synchronous tinnitus. Diplopia, transient obscurations of vision, visual field loss and papilledema improved, and the mean lumbar puncture opening pressure decreased by 20 centimeters of CSF. So ongoing monitoring just really kind of depends on the patient and what their vision loss is. There's no specific algorithm for this, but people can relapse, and they can relapse if they gain weight. They can relapse if they take a medication that causes weight gain or take a medication that's associated with pseudotumor to begin with, like vitamin A, or if their interventional procedure fails. And this applies to any of the interventional procedures. We want to monitor people very closely, women who are pregnant. And again, keep in mind that they may persist in having headaches. That doesn't mean they need a shunt revision. It probably just means they need better headache treatment. So treat the patient, don't treat the pressure. These people have a very poor quality of life. It turns out that headache-related disability is the greatest contributor to poor quality of life. The transient visual obscurations, which have no visual impact, like long-term, they don't predict visual outcome. But if you lose your vision while you're driving, that's kind of a problem. And so that was actually the second greatest factor impacting quality of life in studies, in addition to visual acuity, the brain fog. And there was one study recently, again, done in your neighborhood, that looked at patients during COVID-19, during the lockdown, to see if, because it was harder to get medical care, to see if the fear of COVID-19 differed in patients in IIH compared to controls, and found that there was no difference. Kids with IIH, they're treated basically the same as adults. Before puberty, boys and girls are equally affected. Once puberty hits, the girls take off, and obesity is more common in adolescents. Secondary causes often found in kids. There's no contraindication to women with IIH becoming pregnant. It can develop during pregnancy, but there's no change in that risk compared to female controls that don't have IIH. Well, they wouldn't get pregnant. Female controls with IIH that developed at any other time, they weren't pregnant. There was a study again out of the Birmingham group that found that when they looked at databases, the live birth rate was lower in women with IIH than women who had polycystic ovarian syndrome or the general population. So we usually manage IIH during pregnancy very similar to the way we would manage it at any other time. Repeated LPs might be a good option. Acetazolamide has never been shown to be a problem during pregnancy. We try to wait till after the first trimester, but it doesn't seem to make a difference. And steroids or surgery if needed. You know, there are certain drugs and medications for headache that we can't use during pregnancy, so that can be a challenge. The Birmingham group that found that women with IIH who were pregnant had over a 5-time likelihood of developing preeclampsia and almost a 3-time increased likelihood of developing gestational diabetes following their IIH diagnosis compared to before their diagnosis. So they'd had a pregnancy before the diagnosis and then a pregnancy during the diagnosis. And they had twice as many elective C-sections once they were diagnosed. There's no reason to have an elective C-section unless the obstetrician says there is, because the IIH alone, it doesn't matter if the patient goes into labor or not. But there's no increase to the fetus. There is an increased risk again for all these complications of pregnancy for the women, but not for the fetus. Fulminant IIH means just the patient's going down the tubes right before your eyes. Over days to weeks, this requires a full court press, very aggressive treatment. Sometimes, the patient should be hospitalized. Sometimes that treatment doesn't work. They lose their vision. Always look for a secondary cause. And young women, adolescent females, and women in their early 20s may be more predisposed to this. Things that indicate a bad prognosis: severe vision loss at presentation or visual acuity loss at presentation, uncontrolled systemic hypertension, patients who are profoundly anemic, who a transfusion can help, patients in renal failure, and venous sinus thrombosis is actually secondary cause. It's not IIH, but they often have a bad prognosis as well. In the treatment trial, we found that men, there were only 4 men in the trial, they didn't do so well. Those with high-grade papilledema, decreased acuity at baseline, randomization to placebo, and the presence of hemorrhages on the optic disc portended a poorer prognosis. So in summary, we're going to make the correct diagnosis, use the diagnostic criteria, evaluate for secondary cause. If the patient's on medication that can cause pseudotumor syndrome, we're going to decrease that, take away that medication if we can. They still may need other treatment. So just taking away the medication doesn't guarantee a happy ending. Assess their visual status, treat their pressure, treat their headache. Don't worship the pressure, treat the patient, and ongoing monitoring. And there's where I live now, and I am happy to take your questions. Get you guys back on the...
Thank you so much, Professor Deborah. It was amazing, a remarkable presentation. For me, it was really weird to hear about the couple of neurologists and ophthalmology. It's almost unbelievable. So who the patients come to first, with a headache or with the visual loss to ophthalmology, and how this referral works between the ophthalmology and neurology?
Well, I guess it depends on what the initial problem is, right? If the headache is the biggest problem, they may end up at the neurologist's office. Mm-hmm. If the vision is their biggest problem, they probably end up in the ophthalmologist's office. And if, they often end up in the emergency department. So typically, I think frequently the emergency department is the most likely place that these people are going to land. I mean, I've been doing neuroophthalmology for a very long time, but I've also been doing headache for a long time. And I look in everybody's eyes, okay, that I see in the headache clinic, right? I can't help myself. I'm a neuroophthalmologist too. So I look in everybody's eyes. I've never picked up a case of pseudotumor in the headache clinic. I had one patient referred to me that was seen by my colleague, who's actually movement disorder specialist, who picked up a case of papilledema in the general neurology clinic. But to me, they don't come to headache clinic. They end up in headache clinic, after all is said and done. So usually they'll end up either in the emergency room, I think, or seeing a neurologist first. At least that's what we see here.
Okay. We've got a couple of questions in the chat section, so I'm going to read. Dr. Neurosurgeon Edwin Vasvi from Bulgaria has a 3-part question. First of all,
Madonna,
thank you.
Edwin is here with us. Maybe you want to ask by himself.
Thank you.
From Bulgaria.
Thank you, sir. I would like to thank for the brilliant presentation first. So my first question is about the dosage of the acetazolamide. And
I'm sorry,
how long...
I can't. It's not coming through clearly.
The dosage of the conservative treatment, acetazolamide.
All right, here we go. Dosage of acetazolamide. Okay, I can see the chat.
Yes.
So in the treatment trial, we started at 500 milligrams twice a day, which is pretty standard. And we had patients increase by 250 milligram increments every 5 or 6 days until they either couldn't take it anymore because of the side effects, or they got to 4,000 milligrams a day. And I'll tell you, before the treatment trial, I never used doses that high. You know, I go up to maybe 2,000 milligrams a day, 2,500 milligrams a day, but patients don't like taking the drug. It's kind of a nasty drug. But believe it or not, a fair number of people in the trial got to 4 grams a day. So that's all we could recommend, because that's what we did in the trial. For people that didn't even tolerate the initial dose, we just let them decrease by 250 milligrams, but they had to be on something, right? So the lowest dose I think that we allowed was probably a half a tablet, 125 milligrams a day. And if they couldn't tolerate it at all, you know, we tried to follow them, but obviously they weren't treated. Okay, if it's not effective, when do you stop treatment? Well, it's all about vision, right? So if the patient's vision is not improving, if their papilledema is not improving, if they're, still having transient obscurations, you may want to either add something to it. I use acetazolamide and topiramate frequently together. You kind of need to keep an eye on the metabolic acidosis, but often you don't even need to treat that. I will usually just combine them before I start other things. But it really kind of depends on their vision and what it started out with, right? So, how many days should we try it? You should probably try it for weeks at least before giving up, maybe months. But as long as their vision's not going down the tube and things are going the way you want it to go, then you can leave it. You can leave them on it. All right. For what % of patients of the headache? I don't understand the question.
How often is this diagnosis causing the headaches in the patients?
Over 90% of people have headache who have IIH. And interestingly, and we're not the only ones that found this in our trial, the likelihood that patients with IIH have a prior history of migraine is more than twice what you would expect in the general population. So in the general population, about 18% more or less of women, varies by country, have migraine. In the IIH treatment trial, over 40% had a history of migraine. So is this kind of like a migraine trigger, right? When your pressure goes up, that's what your brain is their brain is sensitized to, and that's why they get headaches that sound like migraine? I don't know, but I thought it was interesting. Do I have long-term data of EP shunt versus sheath fenestration? No, basically all I have is what was shown in the meta-analysis. And I'm happy to send you the a PDF of slides if you want it. But most of the long-term data goes out to about 3 years or so. There's there's not a whole lot that is beyond that. And there are plenty of papers that have been written about failure rates of both procedures. So, we hate it when shunts fail, and you guys hate it even more when shunts fail. So no offense. I try to keep my patients from having to come see you at all, because the shunt's going to fail. It's just a matter of time. So we hate that. What else? Any other questions I can answer for you?
There is no in the chat part, Madonna, but maybe.
You mentioned the perimetry mean deviation. So I wanted to ask about like blind spot enlargement and other symptoms like tunnel vision. How often do the patients get those kind of complaints?
Some people actually complain about their blind spot enlargement. They just don't know what it is. So people will come in and they'll say, it's really weird. I feel like there's something over on my side, but when I turn and look, there's nothing there. Okay, that's the blind spot enlargement. And some people will notice their peripheral vision problem, others will not. But they certainly will notice their central vision problem. And if people have really marked papilledema, that fluid can spill over into the macula, right? So they're going to have central vision blurring, not really lost. They won't have a scotoma, but they'll have blurred vision. And they may even have distorted vision if they have macular edema as well. And that's a sign of marked papilledema. That doesn't happen in mild papilledema. But transient visual obscurations are pretty common. And they're not exclusive to IIH, but I would say IIH is the most common cause. Patients who have optic disc drusen could also get transient obscurations of vision. So it's not uncommon. The thing that people often will not report to you until you ask them is the tinnitus, right? It's like, well, I'm hearing things. So, you know, the people are not going to walk in the office and say, I'm hearing things, because you'll send them to psychiatry. But when you ask them, you know, do you hear noises, not voices, but noises in your head, or whooshing in your ears, or, oh yeah, you know, it's been going on for 3 months or whatever. So that's the one that we have to usually ask about. Okay, I don't recommend surgery for the headache group.
We have one more question from
yeah, I see it.
Business. What's the effect of obesity in surgery on the headache? Yeah, a bariatric surgery.
Probably the nicest study was done by the group in the UK. And their headaches did get better, and their pressures went down. And it's interesting because the older literature, bariatric surgery also helps migraine get better. I don't know why. But you know, the bariatric surgeons, I guess their patients would come back and say, it's so weird because my migraines got better. So again, it's not specific, but bariatric surgery does seem to help headache.
And the last question from Eralp Chetinalp from Çukurova University Neurosurgery Department. Thanks for the great presentation. You do not recommend surgery for the headache group, but we all experience that patients with headache and the higher CSF pressures benefit from the shunt or CSF diversion. It is possible that headache may be the first symptom and the progress into visual loss. What is your rationale not recommending surgical intervention for the headache group?
Well, I'm assuming from your third sentence of your question that these patients really had pseudotumor to begin with, right? They had papilledema, they had definite pseudotumor to begin with. You know, as you guys see, as y'all see, in patients who require shunts for other reasons, these patients become shunt dependent, just like patients with, you know, hydrocephalus become shunt dependent. And so, yes, the shunt works for a while, but frequently the shunts fail. And the only solution is to put in another shunt. And when that happens once or twice, you know, okay, that's fine. But when that starts happening frequently, you know, I think everybody's patience level starts declining. You know, the patient gets disgusted, you guys get disgusted, we get disgusted. It's like, you know, darn shunt, you know, they're just not perfect. So, you know, if possible, we just try to do everything else we can to get their headaches under control. We have a lot of good medicines for headache now. You know, clearly if the pressure is still super high and they have vision loss, shunt might be an option. Optic nerve sheath fenestration may be an option, and stenting may be an option, because they actually all help headache. But I just hate to get not only my patients, but my colleagues into the situation of it's not working, it's not working, it's not working. Because none of us really want to be there. So that's my rationale. It's not a personal attack. I'm trying to actually, you know, help you.
I think we've got the comment that kind of feels the same way. The best shunt is no shunt. So I wanted, like, no one mentioned about the optic nerve decompression surgery. Is it an option in case when the shunt fails, or when shunt is not an option?
Sure, and the other way around is also true. So there are people that have shunts and their vision keeps going down, and so they have an optic nerve sheath fenestration, or vice versa. So it's not that one procedure does the trick for everybody. Mm-hmm. You know, some people will end up having multiple procedures. Mm-hmm. Hopefully those people and our colleagues in the UK will solve this, so we don't have to do this anymore. But I don't know. We'll see. We'll see.
Let's hope for 2023 to bring more insights. Thank you very much. Dr. Hassan, do you have any comments or
I want to thank Professor Deborah Friedman. It was a brilliant lecture. We have also some professors, colleagues among us I wonder if they want to comment. Bektaş Açıkgöz, Professor Bektaş Açıkgöz, Professor Çağatay Önal, and Mustafa Berker, Professor.
I would love to hear from you. I mean, I know that a lot of the literature in this field is generated in Turkey. So
Thank you, Professor
this is your chance to
Deborah.
throw darts at me.
Presentation. Thank you very much sharing your experience with us. I'm originally from Hacettepe University. In Hacettepe neurology, it was proven that in Behçet disease, probably seen in Turkey and in the Middle East, people sometimes have this pseudotumor cerebri disease. And I have seen one patient after thyroid surgery. Hypothyroidism caused this increased pressure. So we have treated the patient with medication, giving the thyroid therapy. That's all. She was completely cured.
Awesome. Yeah, you can see it with parathyroid disease as well. It always makes you wonder, did the surgeon pull out a little parathyroid while they were in the neighborhood? But hopefully not.
Also, anemia, we have seen some, I have seen some patients with anemia. Recently, I had a patient in last week. He had headaches, and we have seen also an encephalocele cell, small encephalocele cell, compressing the transverse sinus.
Wow. Great. Thank you for sharing that. Very interesting.
Thank you.
Thank you, Professor Açıkgöz, and Professor Çağatay Önal and Mustafa Berker. If you are here, maybe you want to share your opinions. Okay, I think they are not suitable. So I want to thank again Professor Friedman, Deborah, and I want to thank everyone who joined us today, this evening. Goodbye.
Well, thank you very much. I
Thank you very
am
much.
really honored, and it was really wonderful to see you virtually. And y'all have a very happy and healthy new year, and much success to you all.
Thank you so much.
Thank you.
Muhterem
You too.
Gatibova says thank you for the presentation. He's a first year medical student.
All right.